Good afternoon. Welcome to our PCMH Learning Collaborative Session 18. A couple teleconference reminders. Please remember to mute your phone when you're not speaking, and if you can, please don't put your phone on hold so that we don't hear any background music. Our objectives for today are welcome. A special presentation from Cheryl Arnold on on-site behavioral health services. She's from Central Arkansas Pediatrics. We will have a PCMH update, which includes PCMH and behavioral health from Dr. Dennis Quo, and some time for questions and open mic. A quick disclosure, support is provided by Arkansas Medicaid. And joining us today is our Arkansas AAP leadership and staff. And Cheryl, I know you're on the phone. Thank you so much for your presentation today, and I'm just going to let you take it away.
Okay, Kristen, thanks. Can everyone hear me okay? Kristen just asked me to share with you all what we have done to increase availability of mental health services for our patients here at Central Arkansas Pediatric Clinic. You'll go to the next slide, Kristen. So today I'm going to discuss the challenges here in Arkansas that we face with mental health services for our kiddos, CAPC's approach, and what we have learned as we have launched into having some mental health services available on site. Next slide. I've identified 4 hurdles that I think are important to acknowledge and to know that we're going to have to address when dealing with mental health services. One of those is access. And I know we all face the challenges sometimes of just finding an appointment for a child or a facility that will take a child when we need to have that care for them. And then there's the patient compliance, or in most cases, parent compliance with the treatment plan, the medication management, and then reimbursement. Next slide. For access, this is our main target in evaluating the options of bringing mental health services on site. And we have really just a space sharing arrangement with Jay Morgan, who is a counselor. We referred to him a lot, but having him on site and having appointments that are available for our patients only has really helped us. It's helped our parents because they don't have to drive to Little Rock. And it's also helped him because his schedule is full, and I think he was as surprised as we were about what a big hit this has been. So our main goal when looking at this was to improve availability for CAPC patients. Next slide. So where did we start? And one of our big questions was, how will it be accepted and how much do we need? How much is enough? So we started, as I said, by talking with Jay. He was very excited about the opportunity to come here. Didn't know how much time, how many appointments we could fill. So we both agreed that we would start slow. We started with a half day a week and found out very quickly that that was not enough because it was well accepted. And then we got to the point, how much is enough? So if you've got, yes, that next slide is fine, Kristen. So around the mid to end of April was when he held his first clinic here. And at that time, he was still seeing some of the children in the school setting. So we would have him in the afternoon after he'd spent the morning at school. As school wrapped up for the year, parents were very excited to have an ongoing opportunity for counseling throughout the summer. We had to increase from our initial 1 half day a week to 2 half days very quickly because we were having to schedule so far out. I think that eventually went to 3 half days per week before school was out. And then during the summer, we had him here full days. And I think at the most we got up to like 2.5 to 3 days per week. He spends Monday and Tuesday primarily in Little Rock seeing clients there. But for Wednesday, Thursday, and Friday, he was pretty flexible to be in our office. Next slide. Then we weren't sure after we got through the summer with school starting back, what would the response be and what would our needs be. So we have been a little creative in his schedule because he wants to be as available to parents and minimize the amount of time school-age kids are out of school. So on most Wednesdays, Thursdays, and Fridays, he will come in and see a couple of patients of a morning so that they can go ahead and get to school, and then he comes back late in the afternoon and has 4 or 5 appointment slots so that he can minimize the time they're out of school by being checked out early. And he even works every other Saturday if there's a demand for that. Kim just corrected me. He has started coming every Saturday. That is, it's awesome. That next slide was one of our other big questions is, will it be accepted? I think just from what I've already gone through with you regarding how we've had to increase availability, our patients love it. And the kids are comfortable here also. Jay says he has better compliance with people keeping appointments here than he does when they're scheduled with him in Little Rock. His input on this is that, 1, it's more convenient, but 2, it's familiar to them. They're not taking their child to another place, and it just all fits really well. He happens to use an office that is right next door to my office for his counseling sessions, and I hear him have to remind the children that they don't have to step on the scale today because they're just used to coming in and weighing and going to see the doctor. So they are very comfortable here, and we have very good feedback from our parents on that. The next slide. How much is enough? I think we're still trying to figure that out. Even with these multiple days a week at this point in time, we're often booked out longer than we would like, especially for a new patient that we're trying to get in with him. Some of the things that I've talked with Jay about, we haven't implemented any of these yet, but just some things on our radar would be him beginning to do some group sessions for parents who have children with similar issues, some parenting classes, focusing on discipline, how to help your child in school, and those types of things. The next slide, please. So we're at a point now, we've got Jay in here. Is this going to be a good long-term solution, or do we need to look at other options? So one of the things that we've launched, or Dr. Stanford has, he began the REACH training a couple of weeks ago. And if you aren't familiar with this, this is a program that trains primary care physicians to be more comfortable managing some of the medications that are used beyond the normal ADHD drugs in children that have multiple mental health issues, often classified as psychotropic drugs, that most pediatricians are not comfortable managing because they've never really been educated about those drugs. We had learned about this program about 1.5 years, 2 years ago and done a little research, but in possibly having one of the doctors attend. However, the sessions booked up so far in advance, we could never get one of our doctors in. And recently, Dr. Peter Jansen, who started the REACH program, he's on staff at Children's now. So they're offering it locally, which is really great for us. And Dr. Stanford was fortunate enough to be a part of the first class that they've started. And if you or your doctors think you may be interested in this, it's a weekend intensive 3-day kickoff to the course, and then over the period of 6 months, they every other week telephone calls, and that just started for Dr. Stanford last week, so we're not far enough into that to see how that is going to progress. And I'm not certain if there are any additional face-to-face sessions or not. Slide. So the big hurdle that we've always experienced when evaluating whether or not to bring mental health services in-house before is billing. If any of you have ever looked into this, you know how unique mental health, billing for mental health services are. One of the issues is that primary care physicians or counselors cannot bill under a primary care physician and get reimbursed at the same rate that they can with working with a psychiatrist. And if they bill independently as an independent contractor and are credentialed in that manner, they also don't get as much reimbursement. So it's almost like cards are stacked against us and want to keep that link solidly with the psychiatrist. And we all know that that is part of the barrier to access. So I have been lobbying to anyone who will listen to me that really the credentialing and the billing rules for counselors needs to be changed so that it is easier for a primary care clinic to support a counselor. My thoughts are that there shouldn't be really any different than bringing on APNs and billing under the primary care physician's name and credentialed similarly. I'm not sure any of the insurance companies share my ideas at this point in time, but I know I've talked to several of you at different times and you share the frustration. Next slide. So then the natural next steps for us and questions would be, do we hire a counselor since this is successful? To have patients to support a counselor being employed by us and dedicated just to our practice. Of course, reimbursement would have to change for that to work. And where do additional screening tools fit into our practice? Part of the training with REACH to familiarize the physicians who participate with different tools, different screens that they can use for with different indications, of course, and how to interpret and use those then to lead you to treatment plans. And then the big question, because anything that we do has to make financial sense, is providing these additional services under our roof makes sense when you look at the space that you would allocate and if the provider could be doing other services rather than providing mental health services at that time. The next slide. So what we have learned, to reiterate, our patients love being able to receive these services at the same location that they see their PCP. We are proud to know that there is enhanced compliance because we feel like that gives the children the best chance for a good outcome. And then there's also enhanced communication between the counselor and the PCP. If there are big issues, Jay just walks down the hall and talks to the doctor. Or if a doctor has a child that they're not sure what to do with, they'll walk down the hall and talk to Jay about it. So the communication between the counselor and our doctors has improved dramatically. The next slide, and this is a slide primarily for those of you who are in MGMA and possibly working on your fellowship. And this just sort of ties the relevance of mental health services into the body of knowledge for practice administrators. And so the tools and the things that have to be taken into consideration when evaluating mental health for your practices, of course, the patient-centered care, which is why we're all on this call today for patient-centered medical home, and then the aspect of operations management. Can you logistically integrate this into your practice without causing disruption or undue burden on your staff? And then the financial management aspect, which would, again, focus on the profitability and the reimbursement and the billing issues related to this ancillary service. And that wraps up my presentation. If you have questions, I'll be happy to try to answer them based on our experience. I'm definitely not an expert here, just talking about what we've been through.
Well, thank you so much, Cheryl. That was incredibly helpful. Does anyone have questions for Cheryl? I know
Cheryl,
Dr.
Hi, this is Stephen Songi from Qualis Health. I was just curious, I missed the first few minutes, but how are you paying for the specialist right now to see patients?
We do not have a financial relationship. We are providing, it's a space arrangement, and he is billing out of his primary practice location, and we are just providing space. So we are not receiving any financial reimbursement from this service at this time.
Okay, thank you.
Does anyone else have a question for Cheryl?
Yes, this is Dr. Patton in Forest City.
Yes, Dr. Patton.
One question I do have, I have the advantage and disadvantage of living between two chapters, both the Arkansas chapter and the Tennessee chapter of the AAP. And one of the advantages is that I've been going through a module of training with the Tennessee chapter for what's called BHIP. I think it stands for Behavioral Health in Pediatric Practice. And I was going to ask Amy if we'd ever consider offering that module to interested people. It does go through both medical issues like medical treatment for kids with behavioral problems, but even more important, part of the training every time I do a module is that I get a tool that I can screen. It can be a tool for depression, a tool for anxiety, a tool for, I guess, bipolar, a tool for, we're all familiar with the tools for ADHD, but and my understanding, and when I've used them, is that they are reimbursable. Now, that's something that, the doc can kind of order, then a nurse or a therapist could do it in your office and get reimbursed for it. I'm not sure that it's going to pay much, but at least the AAP nationally has given me the codes to use. Has our chapter ever considered that, Amy?
Dr. Patton, we haven't. That is really a great idea. I wasn't aware that the Tennessee chapter was doing that. Is that module actually, was it developed by the national office and the Tennessee chapter is just offering it to their members, or is this something that Tennessee has developed?
No. It's a national thing that Tennessee is offering. The people do the course. There's both online and in-person courses. And they're usually set up for convenient times, like maybe 2 hours after the practice closes. You meet at a location. And the last couple I've been to in Memphis are highly attended. We usually have 30 to 40 docs there and office staff. But I know it's a national program, and all I can say it's capital B, little e, capital H, capital I, capital P. And the people that put it on are a combination of practicing pediatricians, practicing psychologists, and sometimes practicing social workers. So that doesn't solve all of Cheryl and ours problems, but I do know that they show you screening instruments that you can bill for. Sometimes it's called developmental testing, behavioral testing, but the times I've billed it, I haven't had any denials for Medicaid. Insurance, I don't know. As some of y'all know, my practice is pretty much all Medicaid.
Okay, Dr. Patton, let me look into that with the national folks and my colleagues in Tennessee, and I will get more information. I'd also like to cross-reference Dr. Jensen, see what he knows about it, and I will report back to you guys. I may have some questions for you. I might be emailing you. But that's a great resource. Thank you for bringing that up. I'll look into it.
Thank you, Dr. Patton. And does anyone else have another question for Cheryl? That's great, Cheryl, that you're working with the REACH program, because especially because Dr. Jensen, who is our ADHD, he's in charge of the ADHD part. Well, he's part of our program, which many of you are also involved with. And so if you would like more information on that, please let me know and send me an email. And if there are no other questions for Cheryl, I believe Dr. Kuo has joined us for a PCMH update. Great.
Yes, hi, I am here. So thanks, folks. First, I apologize. We had a visiting professor here that I'm hosting, and because of a scheduling glitch, I had to take care of a few things with them. So I'm back in the office. So I just back in the office. And Cheryl, I definitely want to go through your slides and follow up with you about that. But thank you so much for presenting your work with behavioral health with us today. I really appreciate that. And Kristen, we have a little bit of PCMH update, and the behavioral health slides are also in there. I apologize for the scheduling changes because there were a few things I did want to go through in there as well, but we can go through the PCMH update first. Okay. Okay. So I want to take some time for folks to go through some of the PCMH updates. And for 2016, there was one activity metric that we have to attest to. There was one practice support activity metric that we have to attest to compared to 4 in the past 2 years, and those are the care plan attestations. There are, however, a number of practice activity metrics similar to what we have done in the past couple of years that you will need to attest to. And the ones that I did want you to make sure you called your attention to is that there are a few things that are due at the end of March that have to do with the data extraction from the EHR is basically a follow-up for what we attested to at the end of 2015. And the immunization strategy bullet is that is one of the other new practice activity metrics that you will be asked to discuss and attest to in your practice activity portal. The rest of the practice activity portal metrics are pretty much similar, if not the same, as what we were asked to do in the past years, and I look at it as really an opportunity to update on what we are doing in our practices. One announcement to make sure that we know is that there have been some changes and rechanges on how your quality metrics were being assessed if you were in a default pool. And I know folks had, for a while, were also making decisions about entering into voluntary pools instead of being in the state default pool. And the latest was that Medicaid had decided that the quality metrics would be assessed on the individual level, and that if that affects your decision to enter a pool, you can change your designation back to a default pool by February 5th. And if you haven't received that notice or received that letter and you're interested, let us know and we'll get you that information. The 2014, everything should be done for 2014 at this point. The 2015 care plan audit is coming soon, and I haven't personally heard any specific instructions for the care plan audit, except for there should be an option this year for me able to securely email your care plans audits when you are asked to. If anyone has any particular experience or has heard anything more, we certainly feel free to chime in about that, but I know that it's coming soon. Has any folks been approached about a care plan audit yet? Okay, we'll pass along more details when we have them. Kristen, next slide, please. So the 3-month deadline is first to attest to your top 10% high priority beneficiaries, and the second is that you have to enter in clinical quality measure data. Kristen, can you take a minute and update what you know about the top 10% high priority beneficiaries? I know you and I had exchanged a few emails this morning, and I haven't had time yet to follow up on them. I had seen that the lists that are currently in AHIN look like they're updated, but we are not currently recommending that folks go in and do the attestation. They should just go ahead and look at their lists and start thinking about who they want to attest will be the high priority beneficiaries by the end of March.
Yes, I believe that that's probably what people should do, is just look at their lists and make their own selections, but not put them in the AHIN portal. In fact, I had heard from Shelley Ruth today that the lists are not available yet in the portals, and she just said that more information will be coming in the future. But yes, I wouldn't want to have anyone either put anyone in there and have any lists be changed. But I can update everyone when I hear more from Ruth or anyone, or from Shelley Ruth or anyone else.
Because it looks like a fairly new. It just looks like a fairly new list in there already. And so if you see them, the official word from us is don't do the actual designation of high priority beneficiaries yet. That's the official word. Okay, so the other activity for folks to know about is the clinical quality measure data. And there are if we go to the next page, Kristen, you'll see in the next slide that metric A says at the 3-month mark, identify top 10% of your high priority beneficiaries, including behavioral health clients. And the second is report clinical quality measure data for 2015. Diabetes, A1C poor control, controlling high blood pressure, is number 2, and weight assessment for children and adolescents. And if you go in, you'll see that it'll ask you to enter numerators and denominators for those, and it's really your measure of extracting clinical data from your EHR, and that is something you're going to want to attest to. So at the end of last year, at the 12-month mark, we all attested that that you can do these reports, and so you have to enter in the clinical quality measure data for 2015. It does say specifically that they're not going to go ahead and audit that, but they do want you to enter in the numbers and have on file proof that you can run these numbers. So I want to open it up and see if folks have any questions or if folks have any other information to share. Or Kristen, if you've heard anything different about that, I certainly want to make sure that we've got our information correct.
I haven't heard anything different. I'm not sure. So, Stephen and Rhonda are always such a big help to me. So if you'd like to, if either of you would like to elaborate on that, feel free.
Sure. This is Stephen Tongi with Qualis Health. Hello, everyone. I think that the opportunity here that's going to be for most folks, or at least the light bulb that will go off, is that the activity that we have to do at the end of the first quarter is a complete view of 3 different measures for the calendar year for everyone that's in the practice. So what we completed at the end of 2015 was more like an ad hoc report related to 2 of those metrics. So I think that the question that's on the table here for most folks is, do I have clinical quality measures capability within my EHR, and do I have them turned on, and do I know how to pull that data? So this is more of probably a conversation of your super user or the technology folks within your system or clinic, or a conversation that you need to have with your EHR vendor. EHR vendors, many of them have clinical quality measures that they say that they can produce. It doesn't necessarily mean that it's turned on in your system, nor does it mean that that the 9+ that they may that they've told the ONC that they have that they can produce are the same ones that you need for this program. Now, the program has told us that if your EHR can't produce it, a particular measure, that you're not going to be penalized for that. But when we kind of go through quality assurance, that's always a kind of a tricky subject as we move through the year, and it's often a bit of a moving target. But just a little insight, I think, to the difference between the process that we just went through recently for the 24-month attestations and what I expect we have to do at the end of the first quarter.
Thank you so much, Stephen. I really appreciate that. And I see Belinda from AFMC, you're on mute right now, but if you wanted to elaborate or if you have any comments on that, please feel free to chime in. Otherwise, we can keep on going.
At this point, I think Stephen did very well in stating the expectations. So, it all depends upon your EHR. If your EHR cannot report them, then we need to begin to look at what they are capable of.
Belinda, thanks so much. Stephen, thanks so much. I appreciate your input. So folks, for 6 months, if you look at the 6 months, you'll see that those should look familiar to you. Those are, again, practice activity support reporting requirements. And in the 12 months, there's childhood and adolescent and adult vaccination strategy. Next slide. And there's also established processes that result in contact with beneficiaries that who have not received preventive care. The rest of them look fine. Look very similar to last year's. But I did want folks to start thinking about processes that result in contact with beneficiaries who have not received preventive care, as well as the immunization strategy. And I'm thinking that we can go over some discussion of those topics as we go through the year, just because those are new topics. As far as the immunization strategy, immunizations are not currently a metric that is being measured under PCMH, but it is an issue of great importance to Arkansas, as we all know, and the kids of Arkansas. The data in WebIZ is not consistent and reliable enough yet for us to be able to use it as a quality metric, but we are looking at making sure that practices are thinking about those processes. The exact requirements for those, this is a 12-month metric, but they are outlined in those supplemental slides that have been circulating around, and we're happy to go into some of those details as throughout the year. Chris, the next slide, please. So I want folks to also look and make sure that, see if they have any additional questions about the quality metrics that are being tracked for shared savings. And you'll note that there are a lot more metrics this year, and you do have to pass 2 out of 3. But there are a lot more metrics than there were in past years, partly because some of the metrics that were used in past years was sitting on the practice support metric side, and now they've all been put into shared savings. So you'll see that percentage of a practice high priority beneficiaries who have been seen by any PCP within their PCH at least twice in the last 12 months, you'll recognize that those are as a practice support metric in the past, but now it's a shared savings metric. Metric 1, 2, 3, 4, 5, 6 should apply to all of us and should look familiar. Metric 8 is familiar. Metric 9 is new. And take a look at the targets and where you are within those targets, because now is the time to look at your targets and see how well they match up with where you are today, because we're still only in January. Next slide, please. Okay. So metric 15 is the other one that really applies to PEDS practices, and that's percentage of patients 3 to 17 years old who had an outpatient visit with a PCP and OBGYN and had evidence of high weight and body mass index documentation during the measurement period. So that's the other one that's new. Chris, the next slide. Okay. I'm going to finish up with a couple of additional slides that I had hoped to lead off with before Cheryl's presentation. I'll go through these pretty quickly because I think there's just some background for us to think about when we think about behavioral health and PCMH, and then we'll end after that. Are there questions, reactions, comments, things that you want us to work on as we go forward? Okay. Let me go through a few more slides. I've got a couple of things, bits of information at the end that I think will be good for us, and then we'll call it a webinar. So behavior health and PCMH. The reason that we had asked Cheryl to present for us is mental health disorders are common, and the lifetime prevalence for 13 to 18-year-olds is 46% according to the National Institute of Mental Health. And the lifetime prevalence of severe disorder is 21% for 13 and 18-year-olds. The AAP Task Force on Mental Health recommends asking about mental health at every visit, in fact, 2 or 3 questions on mental health. But we know there's also an insufficient supply of behavioral health services, as well as significant regional differences in this state. So next slide, please, Kristen. So the AAP lists 3 different types of arrangements of how primary care physicians and behavioral health specialists can work in separate facilities, and these work together in an integrated system. And we can think about these arrangements as we also think about our practice activity attestations particularly for the medical neighborhood. So there are coordinated arrangements where PCPs and behavioral health specialists work in separate facilities, a co-location where PCP and behavioral health specialists practice in the same facility, and an integrated system where behavioral health operate within the primary care system and are a regular part of primary care delivery. Next slide. So the topic of co-location behavioral health services is that if behavioral health services are located in proximity with primary care, it can result in effective communication, warm handoffs, which means direct introductions, which can reduce the stigma of going to a behavioral health specialist, improve the initiation of treatment, and it may also help you meet standards for team-based care, care coordination, medical neighborhood, and care transition. And you'll see this in both the PCMH activity metrics, but they also apply to NCQA certification if that is something that you're choosing to go to this year. So that's something that we want folks to think about, and we're happy to work with you on this. The last slide I wanted to present on this is the Psych TLC. So how many folks have used Psych TLC in the past? I mean, have folks used or had experience with Psych TLC? Did you know this was out there? Okay, so I want to mention about Psych TLC. I have used Psych TLC. It's a program that's run between the UAMS Psychiatric Research Institute and the Arkansas Department of Human Services Division of Behavioral Health Services. And it makes a child and adolescent psychiatrist available by telephone to provide consultations to physicians, including pediatricians. And if you've got a specific mental health question, particularly if a child can be either in crisis, or if you've got a question based on how do you stabilize a particular situation, this service is available. I have used it. I know a number of folks who have worked on the Psych TLC, who have answered calls on the Psych TLC hotline. And if you call the number, and we can make sure that folks know this number, it goes through the ANGELS program at UAMS, but it does operate 24/7, and you will get a call back from one of the child adolescent psychiatrists within about 15 minutes. And I've used it a number of times in my primary care practice, and it works really well, and they've always been super helpful. So I wanted to make sure that this resource was known to us. I've talked with a number of folks in child and adolescent psychiatry at UAMS, and they say they don't get enough calls, and they know the requests and businesses are out there. So I just want to make sure that folks know about this as well as we start thinking about behavioral health and how to improve our behavioral health management within the primary care setting. So that is all I have. Kristen, is there any more slides? Yes.
Yes.
Do you or Amy want to mention about this?
Sure. Amy, you've been working on this. Do you want to, and let me see if I can switch this over. This is the actual flyer for the Arkansas March 4th and 5th spring meeting. Did you want to talk about it, Amy, or would you like me to?
Yeah, sure. Either way, Kristen, if you want to visit, that's great.
It's okay. Go ahead. You put this together, so I'll let you talk about it.
Well, the AAP is hosting a meeting in conjunction with another meeting that the first meeting actually deals with autism spectrum disorder early intervention. So Dr. Kuo has been a big part of putting that conference together along with some other folks from UAMS and ACH. That is actually going to have some CME available with the conference. We are also tagging on to that, and stick with me for just a minute because it's a lot of information. For the noon hour on that Friday, on March 4th, we are asking the physicians, the pediatricians who would like to attend a noon conference for the residents to leave the Early Intervention Stakeholder Summit and carpool to ACH to be a part of our presentation to the noon conference for the residents. What we plan on doing during that hour is kicking off a resident mentor program, which we will be asking physicians who are practicing in private practice if they are interested in serving as a mentor for a third-year resident who is interested in pursuing a career in primary care. I'm putting together kind of a toolkit of the expectations for a mentor and a mentee, and so for the physicians and the members, that will be forthcoming quickly. So basically at that noon conference, we're going to have Dr. Schluterman talk a little bit in the beginning about the difference in practice settings and kind of start discussing questions that folks might ask a specific practice, be it a private practice, a practice that isn't affiliated with a hospital, or a practice that's affiliated with a larger organization. Then we're going to have a panel discussion with some different folks who are practicing in different settings where residents can ask questions of them. And then the last bit of that noon conference, as you guys know, it moves pretty quickly, but we wanted to offer the physicians who are attending the opportunity to really kind of have a minute with the residents to discuss if they are actually recruiting for a physician within their practice. You know, just hand them your business card, visit with different folks, see, you know, meet the residents, basically. That day we'll end up back at the EI conference for the folks who are attending the Stakeholder Summit. And it's going to end at 6 p.m. with a reception at the home of Chad Rogers and Eric McDaniel. So we're grateful to them for opening their home, and as all of you guys know, it's always a fun time at the Rogers McDaniel home. So we hope that we can get a lot of residents there. We can get a lot of members there as well. This will be another opportunity for those folks who have signed up to be a mentor, to meet their mentee, and also to talk to the residents about different job opportunities across the state. Then on March the 5th, starting at 8 a.m., we're going to meet in the third floor classroom at ACH. We'll have a nice breakfast. We'll kick it off with a quick business meeting for the AAP and our chapter, and kind of go through an overview of where our chapter is financially, what our strategic priorities are, our vision, what we've accomplished, and what we plan to accomplish in the coming year. Starting at 9, from 9 to noon, we're going to do kind of a forum on payment reform. So I've secured Alicia Berkmeyer from Blue Cross Blue Shield, Stacy Zimmerman, who will talk a little bit more about NCQA certification, Dr. Kuo, of course, and David Roten from the Medical Society. Those are the folks who are currently on the panel. We anticipate getting somebody from DHS to talk from the state perspective as well. And at noon, we will adjourn and let you guys go on your way to have your afternoon. We don't want to, oh, and also, I'm sorry, Rob Steele from ACH to talk about the clinically integrated network that ACH is creating and planning to launch. So we certainly don't want to keep you all day. will adjourn at noon and you guys can have your afternoon free. I also would like to offer for any chapter member who wants to attend this, who attends either the noon conference or the cocktail reception or the EI Summit on March the 4th, and then the activities on March the 5th, we have rooms blocked at the Embassy Suites, and so on a first-come, first-served basis, we have a limited number of rooms, but the AAP is happy to accommodate you for your lodging and cover those expenses. So on this flyer, which Kristen, I think is going to email out to all of you guys, there's a Survey Monkey that you can use to register for the conference, and you can register for, just different components of it, and you can also express your interest in becoming a mentor if that's something that you're interested in. So as always, feel free to email me. Feel free to email Dr. Kuo or Kristen if you have any questions. There's also a link to register for the EI Stakeholder Summit as well. So that is a long-winded quick overview of what we're planning on doing this weekend of March 4th and 5th. Any questions?
Thank you so much, Amy.
Awesome, and this is going to be a great meeting, so mark your calendars and let folks know. We're going to blast this out as well.
Can I ask a question before we leave this?
Yeah.
The flyer said something about March 3rd. What time does it start March 3rd at the Pleasant Valley C&C?
You know what, I think that was my mistake. I actually changed that, the newest version of the flyer. I took off March the 3rd. It was my understanding in the beginning that EI Stakeholder Summit was going to be 2 days, but Dr. Kuo, I believe it's only March 4th.
Yeah, so it's definitely just March 4th.
That was my mistake. March 3rd is given back to you guys.
There's no activity on the 3rd.
Nothing on the 3rd.
Nothing on the 3rd.
One other question to Dr. Kuo before he leaves about this issue in front of us. How is this Early Intervention Stakeholder Summit going to compare to some of the information that we received and those of us that participate in the COBALT program?
Which information are you referring to specifically?
The early intervention issue with autism. COBALT to some degree covers that.
Yes.
So I'm just trying to see.
How does it differ from the COBALT presentation?
Right.
Okay. So the COBALT presentation is more about diagnosis, for the folks who are working at COBALT. This brings together the early intervention providers, including what we've worked on with getting folks from a variety of provider groups as well. Folks from TCS, the CHMS, Part C early intervention. Just because we've realized, Joe Fasell and I have been working on this for the last couple of years and realizing just how fragmented the system is to our families and for us as providers. So it's really a discussion on how to get all the different stakeholders in the room and figure out how to, for all of us to navigate, to help our families navigate it successfully. I think it answers some of, it's also to try to answer some of the burning questions many of us have as providers, such as how does a child get referred to, one provider, and next thing you know, you're getting referral to, from a different provider. And it's taken a lot of work to get folks in the same room. But I think that given particularly what's going on in the legislature and kind of discussions about how this may impact, the discussions of the legislature may impact development of disabilities and that community, that getting everybody in the same room and to talk about how we can build a more efficient early intervention system, that's really the goal of the project. So it's really not so much a clinical training type. It's really more of a stakeholder. Let's get everybody in the room and figure out how we can make the system work better.
Okay, sounds great.
Thanks. Anything else? I think with that, we'll close. And thanks for everyone's attention and time today. And we'll see you next month.
Hey, Dr. Poe.
Yes.
Dr. Patton again.
Hey, guys.
I hate to dominate the questions, but I was pausing to see if someone's had something else, but another one for you.
Go ahead.
But before we start, does anyone else have a question? I don't want to dominate the time. Okay.
I have a question for you,
oh.
Dr. Patton. This is Amy. I have a question for you.
Okay.
Would you be willing to be a mentor?
Oh, absolutely. I think this is a program that is 25 years overdue. So, no, I think it's a great idea, and absolutely.
Okay, great. Can I ask you another question? Are you actively recruiting a new physician to come to your group?
Constantly, every year.
Okay, that's what I thought the answer was. The House Staff Office had, and I wanted to visit with you about that. The House Staff Office had a few reservations about asking folks to be mentors who are actively recruiting, but you know, what I would tell them to that is I think everybody is always on the lookout. So
yes.
Anyway, I'll work with them. But yes, I wanted to touch base with you on that. And also, again, I want to thank you for your information, and I'm going to follow up on that, and I'll get you guys an update on that. And hopefully that'll be something that we can offer here in our state as well, especially knowing it's been beneficial for you. So, and then I'll let you and Dr. Kuo visit.
Good.
I'm still here.
Dr. Kuo, can you go back to your very first slide for a minute?
Yeah. Kristen?
Sure.
While we're getting there, I know that if the Qualis folks are still on, they're going to say, good God, what's wrong with Dr. Patton? He asks the same question every time. But I still don't quite understand bullet point number 1, 2, 3, 4, 5. Now, it's easier if I break it down into simple measures. So let me pose it this way and see how you would answer it. Okay, right now I'm in a voluntary pool, but last year I was in a year before. No, I've always been in a voluntary pool, but a different one this year. The question I'm having trouble understanding is when it comes to the cost-sharing metrics, let's assume that you meet all the metrics, the practice support, the gain sharing.
Right.
Now, is it more advantageous financially to be on your own if your costs are low compared to the state average, or to go in with a pool member whose costs are higher than you?
Is it more advantageous to go into the default pool, or whether it's advantageous to go into a group that is higher than you?
Well, to join
a larger group. So do you go into the default state pool, or do you go into a group that is larger than yours?
Yes.
Into a voluntary pool.
But the question, it's really a mathematical one.
It is a mathematical question, right.
If you meet your metrics and the state pool cost averages, say, $2,100, but my costs are, say, $1,800, I have the option of, in the default pool, measuring my $1,800 against the state average, or I can join with other practices whose costs are $2,100, $2,200 near the state average. But I'm having trouble figuring out why it's advantageous to join with a higher cost practice.
As opposed to being in the default pool.
That's correct.
Right. What I'm going to suggest is we follow up by email, mostly because I've seen a few discussions on it, and but I think this is probably something that's I don't want to give you an off-the-cuff answer about that.
Sure.
If you don't mind.
This is Chris Schlitterman. One of the worries that I have with the default pool is now that we've allowed people to voluntary pool, you're basically taking off all of the good practices that are doing well with PCMH that have decided to volunteer pool. And I feel that if you stay in the default pool for this next year, that those numbers are going to change drastically. I feel like the only people that are going to be left in the default pool are those kind of bottom of the barrel practices. So I don't think it's going to be all that accurate to look at last year's default pool data, because this year's default pool is going to be completely different.
Totally different.
Okay. Thanks for that input.
Yeah. And I guess it's...
That's a really good question, though.
Yeah,
I mean,
it's a really good
it's
question.
all about economics. But, Dr. Poe, if there is some way that we could figure out a formulary to help folks figure out what is most beneficial, because that comes down to just a common sense business decision. I think.
Right, and the thing is, I haven't wrapped my and the reason I'm almost hesitating is I haven't wrapped my head yet around like the possible financial implications. So I want to be able to think about that and get it done, especially since I know the deadline is February 5th. And Dr. Patton, you have you're in a voluntary pool right now?
Yes, but I joined a physician whose costs are higher than mine, and so the question should go back to default, where I feel like I'll have a lot of gain share, versus stick with the voluntary pool where our average costs are going to be higher than mine.
Right.
With the default pool, you'll have to meet the metrics on your own, but when it comes to the cost sharing, you're going to get your cost sharing based on the default pool's average cost. So they won't use your cost, they'll use the default pool's average cost.
Ah, I see.
I thought they changed that. I thought that was changed, and now you're measured on an individual level for that.
I think they changed it. Right. See, I think they went to. I think the memo said they went to. They originally were going to do just as default, and then they changed it back to individual assessments, and that's what I wanted to double check.
No, they said that the assessment, so before, they're basically going to last year, where the metrics are on an individual basis, but the cost is still on the whole pool.
The metrics are individual.
What we're proposing is that the pool had to meet the metric on the default pool.
Right.
They changed it to where the metric is on an individual basis, but my understanding, again, I'll look at that email again, is that the cost savings is still based on the aggregate costs of the whole pool.
Well, if we could get a definitive answer on that, that would make the decision a lot simpler.
Right, and that's the big thing about, I don't know what the default pool numbers could change dramatically if we're pulling out half of the practices or 2/3 of the practices. So who knows who's going to be left in the pool.
Yeah. I see your point. I agree.
Okay.
All right. Thanks so much. That's all I got.
We'll follow up with you on that. Okay. Anything else? Okay. Thanks, everyone. Appreciate it, and we'll talk to you soon.
Thank you all so much.